Next up, on the mic, we have Dr. Akash Thomas. He is currently a professor in the Department of Medicine, AIMS Kochi. He is an astute diagnostician who is known for his excellent commitment to providing patient care. Over to you, sir.
Hello everyone. Over the next few minutes, I'll be giving you an overview of non-alcoholic fatty liver disease and approach to non-alcoholic fatty liver disease based on the various consensus statements and guidelines currently available. The prevalence of non-alcoholic fatty liver disease is increasing among adults all over the world. Unfortunately, this trend is also seen among children and adolescents. This is basically because of the changes in the lifestyle and the increased incidence of childhood obesity. In fact, it has become one of the most common cause of chronic liver disease in Western countries. It has become one of the primary indication for liver transplant in many of the countries. In our country, the prevalence in our country is 9% to 32% of the general population. Considering the gravity of the situation, the Government of India has included it under our flagship program for non-communicable diseases, that is the National Prevention Program for Control of Cancer, Diabetes, Cardiovascular Disease and Stroke. There is a strong association between fatty liver disease and metabolic syndrome. In fact, the severity of NAFLD corresponds to the severity of metabolic syndrome. It is considered as a hepatic manifestation of metabolic syndrome. There has been a movement to change the terminology from NAFLD to MAFLD, that is metabolic dysfunction associated fatty liver disease. All of us know about the hepatic outcomes of NAFLD, but what we need to stress upon is the independently associated risk, that is NAFLD patients have an increased risk of cardiovascular morbidity and mortality, especially patients with NASH. There is a higher risk of developing diabetes mellitus in patients with NAFLD. The various terminologies by which it was going on was pseudo-alcoholic hepatitis, alcohol-like hepatitis, fatty liver hepatitis, steatohepatitis, and diabetic hepatitis. It is a rapidly evolving field with multiple guidelines and consensus statements. Now, the spectrum of disorders ranges from non-alcoholic fatty liver to non-alcoholic steatohepatitis, which can progress to cirrhosis and hepatocellular carcinoma. All guidelines have agreed on the fact that it is characterized by hepatic steatosis in the absence of secondary causes and the absence of excess alcohol consumption. What they disagree upon is the definition of excess alcohol consumption. Now, the Indian guidelines and the Asia Pacific guidelines are the most conservative in this, that they have put a cutoff rate of 20 grams per day for both males and females. A 10 gram of alcohol will correspond to approximately 30 ml of distilled spirits example whiskey, or 100 ml of wine, or 240 ml of beer. Now, what is the difference between NAFL and NASH? NAFL, that is non-alcoholic fatty liver, is characterized by steatosis but without inflammation, while NASH is characterized by steatosis with inflammation and cell injury resulting in apoptosis, which can progress to fibrosis and cirrhosis. The established risk factors for NAFLD are central obesity or truncal obesity, insulin resistance, that is type 2 diabetes, dyslipidemia, and metabolic syndrome. There is an association, independent of obesity. It has been found that NAFLD patients have an association with PCOD, hypothyroidism, obstructive sleep apnea, hypopituitarism, and hypogonadism. Now, the pathogenesis is not very clear, but the accepted hypothesis is the main thing is insulin resistance. Now, along with this, there is a second hypothesis, that is insulin resistance starts off the steatosis, but a second hit in the form of an oxidative injury is required for it to progress into hepatitis, that is inflammation and fibrosis. Some of the other factors that have been implicated in the pathogenesis are the hepatic iron, deficiency of leptin and adiponectin, in the alteration of the intestinal bacterial flora, bile acids, incretins, dietary cholesterol, and obstructive sleep apnea. Coming to the clinical features, majority of the time, majority of patients are asymptomatic. NASH patients can be asymptomatic. Also, they can have vague symptoms like fatigue, They can have vague right abdominal discomfort. Usually they are detected in the NASH is detected in the age group of 40 to 50 years. Some of these patients can have hepatomegaly. Once they develop cirrhosis, they're going to have the common features of a chronic liver disease. Usually it is in the age group of 50 to 60 years. What are the liver function LFT abnormalities that we can see in a patient with NAFLD? One is you can have a normal liver function pattern. The second pattern that you can have is a mild to moderate degree elevation in the transaminases, that is AST and ALT. But the degree of AST and ALT elevation does not correspond to the inflammation or injury. The usual thing is the AST, unlike an alcoholic liver disease where the AST-ALT ratio is more than 1, in patients with NASH, the AST-ALT ratio will be less than 1. One thing that we have to consider is as the disease progresses and the patient goes into hepatic fibrosis, the ALT levels will decrease, and later stages it can be that the AST is more than the ALT. Alkaline phosphatase can be elevated up to 2 to 3 times normal. There can be mild elevation in ferritin, transferrin saturation, GGT, and even a low titer of autoimmune antibodies in the form of the common ones are anti-nuclear antibodies and anti-Smith antibodies can be present in the absence of an autoimmune disease. Now, if you find that the ferritin is more than 1.5 times the upper limit of normal, it is usually associated with a higher NAFLD activity score and thus NASH and with hepatic fibrosis. It is a clue. In patients with cirrhosis, there is not going to be any difference in the LFT abnormality when you compare with the other etiologies of cirrhosis. Imaging. Imaging can detect non-alcoholic fatty liver disease, but it cannot differentiate between a non-alcoholic fatty liver and NASH. The first modality of imaging is ultrasound. Ultrasound will show a hyperechoic texture or a bright liver because of the diffuse fatty infiltration. It has got a sensitivity of 85% and 95% specificity for detecting when the patient has at least 20 to 30% steatosis. Less than that, the preferable imaging would be CT or an MRI, MR spectroscopy to be exact, for detection of hepatic steatosis. But these are not commonly used because of their availability, expensive, and the time required for these tests to be done. In the ultrasound itself, we have the ultrasound-based transient elastography, which has been routinely used to detect fibrosis based on the liver stiffness. It is also being developed to grade the hepatic steatosis, but additional data are required as per the various guidelines that are available. Now coming to steatosis, all guidelines do not advise or recommend any specific testing or scores for steatosis, while the Asia Pacific and the European guidelines, they recommend the usage of fatty liver index score and the NAFLD fat liver score for the presence and not for grading or the severity. The fatty liver index is based on the triglyceride level, body mass index, waist circumference, and GGT, while the NAFLD liver fat score is based on the presence or absence of metabolic syndrome, diabetes, fasting serum insulin, and aminotransferase levels. Coming to the fibrosis assessment, Asia Pacific guidelines do not give any specific recommendation regarding any specific tests or algorithms for the assessment of fibrosis, while the European guidelines and the AASLD guidelines recommend the usage of the fatty liver score, the fatty fibrosis score, FIB4 score, and the usage of elastography. The American guidelines do not recommend the sequence or the algorithms, while European guidelines prefer to start off with the fatty liver, fibrosis score and the FIB4 score first, and then progress on to requirement of elastography and where required liver biopsy. What are the risk factors which are associated with advanced fibrosis in a patient with NAFLD? There are two patient-related risk factors and disease-related risk factors. The patient-related risk factors are: one, use of alcohol, a BMI more than 28, patients who have diabetes mellitus, and older age, that is more than or equal to 50 years, have an increased risk associated with advanced fibrosis. While the disease-related risk factors include histological evidence of inflammation, ballooning degeneration, Mallory-Hyland, or fibrosis on biopsy. While the lab test is elevated serum aminotransferases more than 2.5 times the upper limit of normal, that is AST and ALT. Coming to liver biopsy is considered as of now the gold standard for diagnosis of NAFLD. It is the only method that is currently available to differentiate fatty liver from steatohepatitis. Now, liver biopsy is indicated only in selected individuals. All guidelines, different guidelines have different. The Asian guidelines say it's only indicated if there is a presence or you're suspecting a severe presence or severity of a coexisting liver disease cannot be excluded, or you want to assess the fibrosis when non-invasive testing is inconclusive. While the American European guidelines advise it, recommend it for if you're having a suspicion of advanced fibrosis or to confirm the findings and for prognostic implications and management. Now, the practical implication of this American and European guidelines is one, we do not have a specific treatment for the management of NAFLD. Secondly, most of these patients have associated comorbidities, and being an invasive procedure, many times it is risky to do this procedure. So to summarize liver biopsy, only if you have an uncertain diagnosis or you're suspecting NAFLD related advanced liver disease are there indications for doing liver biopsy, which is an invasive procedure. Coming to the diagnosis, all guidelines agree on the same diagnostic, that is demonstration of hepatic steatosis by imaging or biopsy. 2. Exclusion of significant alcohol consumption, exclusion of other causes of hepatic steatosis, and absence of coexisting chronic liver disease. In other words, this is demonstration of hepatic steatosis and exclusion of other conditions. That means it is basically a diagnosis of exclusion. So when you have a suspected NAFLD, what are the other common disorders that we should rule out? One is alcoholic liver disease, hepatitis B, and hepatitis C. In the right context, in young individuals, Wilson's disease, hemochromatosis, thyroid disorders. If you are suspecting an autoimmune etiology, you think about workup for autoimmune hepatitis. When required, based on the history, drugs should be suspected. Starvation can produce altered liver function. In specific context, that is, you can consider acute fatty liver of pregnancy or HELP syndrome. Now, what about screening for NAFLD? All the guidelines recommend that screening for general population is not recommended. Now, specifically for high-risk population, the American guidelines, AASLD guidelines, do not recommend screening even in high-risk groups, but they advise to keep them under observation. While the Asia Pacific and the European guidelines specifically mention patients with obesity or diabetes, and the European, in addition to that, have mentioned metabolic syndrome or patients who have persistent abnormal liver functions, liver enzymes to be screened for NAFLD. Now let's talk about the treatment options available for patients with NAFLD. You have two treatment options available. One is lifestyle intervention and another one is pharmacological treatment. We'll start off with the lifestyle intervention. All guidelines agree on one thing, that diet, exercise, and weight loss are the lifestyle interventions that should be implemented in patients with NAFLD. Now, out of this, weight loss is your keystone for improving the histological features of NASH and reversing the disease. Now, weight loss should ideally be gradual. Rapid weight loss is not advised at all. It should be a gradual weight loss. A targeted weight loss of 7 to 10% of the body weight over 6 to 7 months would be an ideal way of reducing weight. How would you achieve that? It should be ideally with a combination of diet and moderate intensity exercise. Now, what is the type of physical exercise it should be a combination of aerobic exercise and resistance training. Now, the resistance training is important, especially in our context. A combination of resistance training is important in our context, especially when you consider that we have patients with lean NAFLD, which I will be coming to earlier, which resistance training will improve the muscle mass. What is the diet that is recommended? Most guidelines do not give any specific diet, but there is an agreement that a Mediterranean diet would be the most effective in reducing weight loss and bringing about the beneficial effects on the associated cardiometabolic risk factors, which are usually associated with NAFLD, like hypertension, diabetes, dyslipidemia, truncal obesity. For those who are obese, a daily calorie deficit of 500 to 1000 would be ideal. Like I mentioned earlier, the Asia Pacific and the American guidelines do not recommend any specific diet or exercise regimen, while the European guidelines specifically mention ideally it would be a Mediterranean diet with avoidance of processed foods and added fructose. Now, what about alcohol consumption? No guidelines are giving any recommendation, but the consensus is that once a patient has developed NAFLD, it would be ideal to avoid alcohol consumption of any type or any amount in patients with NAFLD. Coming to the pharmacological intervention, I would like to start by saying there is no approved drugs as of now to treat NAFLD and NASH, though a lot of research is going on. As of now, there is no approved drugs to treat NAFLD or NASH. So what is the treatment aimed at? The treatment is directed at the coexisting metabolic disorders. Now, based on the guidelines, we look at some of the drugs. Asia Pacific guidelines, pioglitazone is recommended only in patients with pre-diabetic or diabetic NASH, that too with a limitation that it should be for a short-term use. As per the Asia Pacific guidelines, there is no firm recommendation made regarding the use of vitamin E due to insufficient evidence. Coming to the European guidelines, they advise pharmacotherapy to be reserved for patients only with NASH fibrosis, that is on histologically stage F2 or higher, or NASH with a high risk of disease progression, that is risk factors like diabetes, metabolic syndrome, elevated ALT. They do not have any firm recommendations for the use of pioglitazone or vitamin E. Coming to the American guidelines, American Association of Liver Disease, vitamin E high dose 800 international units daily they have said can be considered in non-diabetic patients with biopsy-proved NASH without cirrhosis. Now, pioglitazone 30 mg daily can be considered in patients with and without diabetes, again with limitation that it should be biopsy-proven NASH. We will go through some of the common drugs that we have been using in our day-to-day practice. Starting off with the ursodeoxycholic acid, which has been widely used. It is based on the concept that bile acids have a role to play in the pathogenesis of NAFLD. One positive factor here is there is abundant data on the use of ursodeoxycholic acid on the safety of long-term use in liver disease patients. So it's been used at a dose of 300 mg/BD or 150 mg/BD, but no guidelines as of now recommend it. Coming to silymarin, it has been mentioned as a potentially useful treatment for NASH in Asia Pacific guidelines only. But they have specifically mentioned that the optimal dose and the duration requires further studies. Now, some of the because diabetes is it is associated with like I mentioned earlier, NAFLD is strongly associated with metabolic syndrome, and one of the important components of metabolic syndrome is obesity and diabetes. So, in patients with diabetes, we usually use metformin, pioglitazone, and now GLP-1 analogs. So, what is the role of metformin? The role of metformin remains uncertain with respect to NAFLD, though it helps in diabetes control and it has a role in the insulin, it plays a role with insulin resistance. As of now, it is not recommended by any guidelines to specifically treat NAFLD, but you can use it for the treatment of diabetes with NAFLD. Coming to pioglitazone, it has been endorsed by certain guidelines, but with significant limitations. One is that it's short-term use. This to be used only after careful evaluation. The American guidelines specifically mention that this should be in a biopsy-proven NASH. The side effects commonly attributed to it are weight gain, edema, worsening of pre-existing heart failure, and fractures, especially long-term use in females. The long-term safety profile is not very clear as of now. GLP-1 analogs. New evidence has come that the GLP analogs acting on the glucose-insulin interplay, which has a role in the pathogenesis of NAFLD, to have some favorable results. But the guidelines do not give any recommendation as of now for the treatment of NAFLD, but you can use it in patients with diabetes. Coming to a commonly used drug, because dyslipidemia, obesity, dyslipidemia is part of the metabolic syndrome. What about the role of statins? All the guidelines specifically say that there is no increased risk of hepatotoxicity or side effects for the treatment of dyslipidemia in patients with NAFLD. It can be used safely even in patients with NAFLD, even in the presence of raised transaminases. All of the guidelines agree about the safety of prescribing statins, that is, you can starting newly or you can continuing the ongoing statin therapy in patients with NAFLD, even with compensated cirrhosis. Now, routine prescription is not recommended in two categories. One is if the patient has got decompensated cirrhosis and if the patient has got acute liver failure. What about vitamin E? The long-term safety profile is not fully established because the long-term safety, there are some studies saying that there is an increased risk, especially with high-dose vitamin E, with respect to prostate cancer and an increased cardiovascular mortality. It is recommended by NICE and the AASLD guidelines, but it is limited to biopsy-proven NASH, especially with the American guidelines. The European guidelines and the AISF guidelines recommend that more evidence is required before any recommendation can be made on vitamin E. In fact, the Asia Pacific guidelines advise against the use of vitamin E in the treatment of NAFLD. Surgical options available are, one is bariatric surgery. It is found to be having a role to reduce the steatosis and inflammation, but not on fibrosis. Liver transplant, like any patients with cirrhosis, the etiology of NAFLD also is not a contraindication for liver transplant. Now, a few words on lean NAFLD, which is very common in the, which is more common in the Asian population. It is defined as NAFLD that develops in patients with a BMI less than 23 in Asians or less than 25 in Caucasians. What is the prevalence? 5 to 20%, 26% of the general population in Asia and 7 to 20% in the Western world. It is found that lean NAFLD is more common in the Asian population compared to the Western world. The exact mechanisms are not understood, but some of the mechanisms that have been implicated are, one is dysfunctional fat. That is, these patients with lean NAFLD, that means their BMI is normal, they have more of visceral fat, visceral obesity and visceral fat compared to subcutaneous fat. They have an altered lipid turnover. They have an altered body composition, that is decreased muscle mass. Though they are lean, they have a decreased muscle mass. That is where the role of resistance training will help in this lean NAFLD. They have a genetic background. There is a different pattern. That means there is an alteration of the gut microflora in these patients. Some of the possible causes of NAFLD in lean subjects based on the available literature are, one is the high intake of fructose intake and high fat intake, fructose and fat intake. Metabolically obese normal weight subjects, that means we should not be relying only on the BMI. One should look at the waist hip ratio because the truncal obesity will play a role, visceral fat plays a role. Congenital or acquired lipodystrophy, especially patients on example antiretroviral therapy, malnutrition, genetic predisposition, some of the endocrine disorders like PCOD, hypothyroidism, growth hormone deficiency, drugs, jejunal ileal bypass, starvation, total parental nutrition are some of the causes that have been implicated. Now, though lean NAFLD patients have a favorable metabolic profile when you compare them with the obese NAFLD patients, they can develop the full spectrum of liver damage that is described in an obese patient. Now, the data on long-term prognosis is not sufficient with respect to lean NAFLD, but whatever available data suggests that NAFLD is not a benign disease. The general recommendations, like in a patient with obese NAFLD, is applicable in a lean NAFLD patient also, including the adoption of a healthy lifestyle, initiation of pharmacological treatments for the risk factors like hypertension, diabetes, dyslipidemia. Now, habitual physical activity should be emphasized also in patients with a lean NAFLD, because here it's not about weight loss, but rather it is proven to decrease the visceral fat. Now, a few words on the Indian scenario. What has been found is that 9 to 30% of our general population have NAFLD. Obviously, this is going to be even higher in the high-risk population, that is patients with metabolic syndrome. Nearly half of our NAFLD patients have metabolic syndrome. There is a high prevalence of insulin resistance among our population. The higher insulin resistance and the higher hepatic triglycerides in Indians in comparison to other races suggests that the Indians, we are more prone for developing NAFLD. Iron overload and HFE gene mutation do not play a major role in the pathogenesis of NAFLD in Indians. It has been found, it is based only on the minimal literature that's available, that there is a mild histological disease at presentation in Indian population compared to the Western population. Lean NAFLD is more common in our setup. It has been found that the hepatic fat content of Asian Indians is almost twice the amount for similar BMI when you compare with the white Caucasians. Take-home message from my talk would be: 1. The strong association between NAFLD and metabolic syndrome. The fact that NAFLD is an independently associated with cardiovascular morbidity and mortality, and there is an increased risk of developing diabetes mellitus in NAFLD patients. So obviously, we have to do a metabolic risk factor profiling, that is screening for diabetes, hypertension, dyslipidemia, obesity, sedentary lifestyle have to be corrected. They have to be identified earlier and treated so that we can prevent cardiovascular and liver-related mortality. Lifestyle intervention will help in the prevention and the treatment of NAFLD. Thank you very much.
On NAFLD, so we have a few questions actually. So one question we had been asked was, what is the role of fructose? So what is the role of fructose in the pathogenesis of NAFLD, sir? Does fructose have anything to do with NAFLD?
Sorry, Subhash, could you repeat the question, please?
Sorry, sir, we wanted to know, so does fructose have any role in the pathogenesis of NAFLD, sir?
Definitely. What has been found is, especially lean NAFLD, also in obese NAFLD. Now, I would like to clarify one thing. We are not talking about the fructose that is present in fruits. Understood. The fruits, because in all the diet we say take good amount of fruits. That is minimal. That fructose is minimal and it's not harmful. What we are talking about the fructose is the fructose that is added, for example, sweetened beverages. Understood. 1, 2, any sweetened items nowadays, they are using large component of fructose. The reason is because fructose can help in the storage of food items. 2, fructose does not leave a lingering sweetness in the mouth when you consume it. So when it's added to the products, it gives sweetness, but it does not leave behind any lingering sweetness, so it doesn't affect them. Third thing is, it also helps in the storage of food products. So when you take the processed food items, when you take the sweetened beverages, the carbonated beverages, the increased consumption of this fructose plays an important role in the pathogenesis of, because you are taking increased carbohydrate, increased fructose, it plays an increased role in the pathogenesis of NAFLD.
Okay, thank you, sir. So actually, we had one more question. So what about, sir, how common is hepatocellular carcinoma in NAFLD? Is NAFLD independently a risk factor for HCC, or is it only when it becomes NASH only progresses like that? Anything is there?
Like as I mentioned earlier, the slide, NAFLD, you have two things, that is fatty liver and NASH. Fatty liver is a benign condition. It just remains as a fatty liver. Only if it progresses to NASH, all of our complications, that means it can progress on to cell injury, inflammation, cell injury, and thereby apoptosis, thereby cirrhosis, and the next stage is hepatocellular carcinoma. So if the patients are only fatty liver, we need not be worried. Only thing we should prevent the progression to NASH. But patients with NASH, yes, there is an increased risk. 1, no screening is advised in NASH patients for hepatocellular carcinoma as of now. It is only if they develop cirrhosis. Once they develop cirrhosis, it's just like any other cirrhosis patients. You monitor with the alpha-fetoprotein, with the ultrasound, all those modalities, like in any patient. Secondly, there are studies coming in saying that there's just few studies. So the guidelines have not put it into guidelines there, but they have noted these case reports that are coming in, that patients with NAFLD, that is NASH, without developing cirrhosis, can develop hepatocellular carcinoma. What has been the literature that is available is 3% of patients with NAFLD related cirrhosis can progress on to hepatocellular carcinoma. And finally, conclusion of that point that you asked, the patients with, is there a difference in the hepatocellular carcinoma occurring due to NAFLD and non-NAFLD? What they have found is, because of the increased incidence of metabolic syndrome in patients with NAFLD related cirrhosis, that is hypertension, diabetes, dyslipidemia, most of these patients have increased cardiovascular mortality and morbidity. Therefore, if you look at the prognosis of HCC due to NAFLD and non-NAFLD, obviously the NAFLD has a worse prognosis.
Sir, and so is immunization mandatory in NAFLD? like the hepatitis B vaccines and Z vaccines. So, sorry, the hepatitis B vaccines, is it mandatory in all NAFLD patients, or
it is not mandatory? It's a very good question. It's not mandatory, but it is advisable. Why is it advisable? Is in patients whom you are suspecting NAFLD, what they advise is if these patients develop superimposed hepatitis A or B, obviously there can be worsening of the disease because it's a two coexisting conditions. So whenever there are two coexisting conditions, it can worsen. So it is advisable. In cirrhosis, obviously, as per the guidelines of cirrhosis, all the adult immunization, even in a fatty liver or a NASH, it is advisable. What they advise is at least hepatitis A and B vaccination if the patient has not suffered from any of these in the past, or if there are no serological evidence of immunity, it is advisable to go ahead with vaccination, even in a patient with fatty liver or NASH.
Okay, sir. And so we have heard of DASH diet in hypertension. So is there any role for DASH diet in NAFLD?
Yes, they have compared the DASH diet and the Mediterranean diet. What you asked is a very good question. It's the Mediterranean diet is more of fruits, vegetables, nuts, avoiding processed food. DASH diet is restricting because it was basically used for the control of hypertension. It is restricting the salt intake to 2.4 grams. The same thing like fruits and vegetables, but the DASH diet gives a little more leeway. That means increased intake of of the in the dairy products compared to the Mediterranean fat. When they compared it, it's also got equal effect on the benefit, not only on the NAFLD, also on the metabolic risk factors. But one thing everybody has compared is it should be ideally along with the exercise.
Okay, sir. Thank you, sir. Thank you very much for your words, sir. And sir, now we will conclude the sessions, academic sessions. Thank you, sir.
Thank you very much. Thank you.
So we have come to the end of our academic sessions. Initially, we had a few glitches, some echoing, please bear with us because this initial problems are not anticipated. So we wish you can join us later at 7 p.m. for the live case discussion, where we'll be discussing a neurology case at 7 o'clock. Till then, thank you. Thank you. Thank you for joining. One more thing I would like to add is if there is if there are questions which you have not answered in the chats, we will get across and we will answer these questions later. Today, because of the time shortage, it's already 5:40. We are really much behind schedule, so we will be answering them through the chat box or even directly to the people who have asked. Thank you. Thank you.